Okay, thanks. So as you've just been told, I'm currently working in New Zealand, although my home base is Maine, and I was involved with the startup of Maine All Care as well in 2010. And at that point, we linked up with one pair states. So it's been good to get to know all of you over the years. New Zealand decided in 1938, Parliament voted to that New Zealand should provide health care to all of its citizens. And shortly after that vote, that Health Act, they established their system, which has been tweaked and changed and adjusted over the years. But at the moment, New Zealand is divided into 20 regions, and district health boards for each of these regions manage the healthcare for that area. And what I'm going to do is start with a 6-minute video that my current district health board in Wanganui, which is in the southwest of the North Island, prepared to illustrate how they are, their philosophy behind the services. Mike, are you going to show that then?
Yeah, here we go.
Okay.
Everybody hear it?
Maori ora. Nei rā ko te puari o Wanganui e tuku mi atu ki ngā uri o te roe nei ki a koutou o Wanganui. Ngā waireki, ngā tiapa, ngā hauiti, ngā rauru kitai, mō kai pātea me koutou o ngā tirangi. Mai i ngā matapi i taku titiro atu ki te awa o Waitotara, ki te mana o ngā rauru kitai, a ka uri au ki a koe e te awa tipua, e rere kau ana i runga anō i ngā kōrero ko au te awa ko te awa ko au. E rere kau atu te wai ki ngā ngaru e aki ana ki a wanga ehu heke atu ki a turikina awa me ngā wenua o ngā waireki me ngā tiapa. Ka uri taku kāno i kia waia e au i a rangi tīkei awa ki ngā wānau o Ngāti Hauiti me mō kai pātea. Ko te kāui maunga e tū maira me ona kauai kōrero ai maaratanga ki ngā uri kei ona reke reke. Ngāti rangi, koutou ko Ngāti Uenuku, tēnā koutou. Uri noa ki tēnei roe o te puari o Wanganui, tēnā koutou, tēnā tātou katoa.
Ko Russell Simpson, Kai Hautu Hawara, Chief Executive, Wanganui District Health Board. This is our vision for He Hapori Ora, thriving communities, to support stronger and healthier communities that thrive in the Wanganui, South Ruapehu and Rangatiki districts. Kia tae e te wānau me te hapori e tono aki tino rangatiratanga. Together we build resilient communities, empowering wānau and individuals to determine their own well-being. Over the next 3 years, we will work towards reducing inequities in health, particularly for Māori, supporting collective community decision-making by working with our partners in care, and keeping people healthy in their own homes and communities.
When people or communities face unfair and unjust barriers, they often don't get the health care they need and are entitled to receive. Age, gender, socio-economic position, ethnicity, impairment, or even where someone lives. These can all be barriers to receiving quality health care, particularly for Māori. Hawara Āiwi and the District Health Board are committed to a pro-equity agenda that is based on achieving health equity for our entire population, the diverse communities and groups that call our region home. We need to do things differently, to put in place systems and processes that minimise barriers such as cost and access to services. This means working with communities and leaders across our region to address the social, cultural and economic factors that impact on our health and well-being. It's about continuing to build our Māori workforce, to introduce solutions such as Maori models of care and whānau ora approaches that work for our region, our communities, and more especially our people.
Understanding one another and working in partnership is the key to success in addressing the social determinants of health. Working in a social governance model enables us to work closely with iwi, community, social and government organisations towards a common purpose, enabling thriving and more healthy communities in our ro'i. This means we will be sharing, supporting information, funding, data and technology. We will empower our local leaders to solve local problems through co-design systems and challenge the way we all work, breaking down traditional, regional and organisational boundaries. This is us, as a whole ro'i, supporting each other to thrive across all aspects of well-being, mental and physical, education, employment and housing, by aligning our resources, knowledge and commitment to our communities.
The third area, keeping people healthy at home, ties pro-equity and social governance together. This is about keeping people healthy in the community as opposed to in a hospital. This doesn't mean people aren't admitted to hospital when urgent care is needed, but it is about working towards preventing health conditions which result in hospital care in the first place. When people need care, we must consider what support can be delivered in the home or in the community. We also want health and well-being in the hands of the individual and whānau by making sure they know their options and are educated about their health needs. This is a meaningful but challenging shift, which is a community-based option rather than hospital-based.
Thank you for finding out more about the Wanganui District Health Board's strategic vision to support building resilient communities, empowering whānau and individuals to determine their own well-being. If you want to read more, go to wdhb.org.nz/thriving to find out more. We hope this video has given you more information about our 3 focus areas that we're working on as a District Health Board in partnership with our communities for every one of the 69,000 people within our ro'i. He waka e ke noa, we're all in this together. Kia ora.
So this was on the screen of my homepage on the intranet at work when I arrived the 1st of November. And I was just really impressed at the view of the whole picture, not just the hospital itself and the employees of the hospital, the doctors and nurses, but really the health board is owned by and everyone has a say in the community. And equity has been a main focus, especially over the last 3 years, because there are disparities. And you'll hear about Maori, which I saw Chuck noted in the chat. Maori are the indigenous population of New Zealand. They arrived sometime around 1400. And the country itself is bicultural and is renegotiating a treaty that was signed between the Maori and the British well over like 150 years ago. So so that drives a lot of life in New Zealand. And in fact, later this year, they're going to be reorganizing the health system again to hopefully also include Maori and Maori health in a more prominent role. So anyway, I prepared 10 pages of illustrations about the New Zealand health system, and most of it comes from the Commonwealth profiles of different countries. And I use this when I want to look at healthcare in other countries as well. So New Zealand has about 5 million population. During the COVID response, our Prime Minister refers to New Zealand as the team of 5 million. in addressing COVID. I've been told to think of it as about the size of the state of Colorado in population. 15.4% of New Zealand's population is over age 65. Next page. New Zealand spends less than half of what the US does per capita on healthcare. And New Zealand is still significantly under-resourced in the area of health. However, overall, in my opinion, they do a lot better job of spending $4,000 to $5,000 per capita wisely than pretty much anywhere in the world. Total health spending was 9% of GDP in 2017. It may be 10 or the last 10 or 11%, particularly as they've had to devote more and more resources toward COVID. Public spending accounted for almost 80% of total spending, although 30% of people do have some private insurance. It accounts for only about 5% of total health expenditures. It's not that expensive, and what it does is enable people to access certain services privately rather than being on a waiting list. And out-of-pocket accounts for about 13% of total health expenditures. On comparisons with other countries, New Zealand does have some significant issues with access, that even with very low copays for people living in poverty, it does prevent them from seeking primary care services. You can go on to the next slide. There are basically 4 parts to New Zealand's health system. Much of the funding, I don't know the exact percentage, goes to the district health boards, which nearly fully fund hospitals, specialists, disability services, and funding for that also goes to different private nonprofit organizations that provide community support services. It's the hospital and specialist services are funded for permanent residents and citizens. Non-residents such as myself, if I were to be hospitalized, I would probably be billed. But just like some other places in the world, if I were to end up in the hospital with pneumonia or something, I might get a bill, but I might not, because first priority obviously is to provide the services, and they're not budgeted to have to, well, the budget includes they have global budgets, so that a person who's a non-resident coming in for an urgent need is not likely, is not at all likely to be turned away. New Zealand also has a no-fault accident compensation program called ACC, and it is available to both residents and non-residents and tourists. So if I were to be injured bungee jumping or in a car accident, I would also be covered by ACC. It's led to kind of a interesting inequity or disparity in that, for instance, if you were drunk driving, got in a severe accident and became paralyzed, you would get all of your health care related to that and things such as a motorized wheelchair and all of that through ACC. Whereas if you became paralyzed because of a neurologic condition, say multiple sclerosis, you might not be eligible for the same sorts of supports as you would if you became disabled because of an accident. Then the third part of the system is the primary care system. And this is where I think New Zealand could do a lot better. And they will say that they don't, they'd have to raise taxes and that it's working pretty well the way it is. But primary care is funded kind of partly capitation, and then visits to GPs, which is what they call PCPs, general practitioners, are only partially subsidized. So New Zealanders have a copay, which would be anywhere from $10 or $15 up to $70 per visit to their GP. And that causes a lot of people to delay care. And it causes some people to then wait until their conditions are severe enough that then they go to the emergency room, which is fully funded and there's no copay. Also, prescription drugs are nearly fully funded, but there's a $5 copay per prescription, up to 20 prescriptions per year. And that $100 per year is a barrier for some people, although people who are on disability, the New Zealand equivalent of Social Security or welfare, can then take their receipts to the welfare office and get reimbursed. But just the hassle of doing that causes a lot of people to just say, oh, I'm not going to get my prescriptions. Next, well, also I'll talk a little bit at the end about how they manage their pharmaceutical and medical device budgets and purchasing, because I think that's really their system for doing that is something that I think everyone should look at as a means of controlling prescription drug prices. Okay, you can scroll through the next couple of pages. This just shows that 100% of the population has public coverage, and about a third have some kind of private insurance, but it's not really needed that often. So it's very inexpensive. Next page. This is from the Commonwealth Fund article, and I'm not going to go into it in detail, but it just shows typical co-payments and safety nets, and no charge for specialist consultation. For instance, someone who would be referred to see me for mental health services, there would be no copay at the time of service. And same with hospitals. And I will talk in a bit about the prescription drug benefits system. The next couple of pages, just to show by way of comparison, that despite spending half or less as much money, New Zealand is fairly comparable to the United States in terms of its health system capacity, that people go to the doctor about the same amount. There are somewhat fewer nurses per 1,000 population. And that's kind of despite the fact that particularly in outpatient and mental health, nurses are really the backbone of the workforce in those areas, as well as in the hospital. And almost all of the nurses, particularly all of the hospital nurses, are unionized. And in fact, the doctors are unionized too. So it's helped keep the working conditions tolerable for all of us, even though there is at times overwhelming need and demand. Next page. And again, despite spending a lot less than the US, health outcomes are better than in the US. Next. This is about New Zealand's medicine and medical device system. It's called Pharmac. This is a screenshot of the homepage if you were to Google Pharmac, and it will, if you go there, it'll tell you a lot about how they work. But essentially, they're given a budget every year. Last year, their budget was about $1 billion. And they take that budget and they look at their current drug formulary and also devices, insulin pumps, pregnancy tests, rapid antigen tests, etc. And they negotiate with the different companies about cost. And I've used specific examples from New Zealand when I've given testimony at the state legislature. For instance, my husband is on an inhaler, and out of pocket, or even using GoodRx or something like that in the US, it's several $100s per month. And he pays $5 per month here for the inhaler. And the New Zealand government has negotiated a cost of, I believe it's between $30 and $40 for that inhaler. And the New Zealand government fully subsidizes that cost. So the $5 copay is really the person's contribution to the pharmacy to take care of some of the pharmacist costs in dispensing the medication. I'm currently taking an osteoporosis medicine, and in the US, it's relatively cheap if I get the generic version, that I don't also have to take vitamin D, but there's the brand of Fosamax that includes a weekly dose of vitamin D in it. It's much more convenient for me. And again, I pay $5 for 3 months. And the Pharmac negotiated price of that prescription is $4 with the company that makes Fosamax Plus, as opposed to in the US, they would charge, I think it's something like $100 for 4 tablets of the brand name Fosamax. There are sometimes Pharmac doesn't get it right, and there's a lot of public outcry, and the doctors let them know as well, and they will go back and negotiate to get say a different generic brand. In 2008, when I was in New Zealand, there was an issue with the company or companies that they were obtaining levothyroxine from. And after enough people said, it's really not, I don't feel good taking this medicine. The previous funded brand is much better. And after enough requests to switch, they renegotiated and got that medicine back. There are some cancer drugs that are not immediately available that Pharmac will wait and see how they're working in the rest of the world before negotiating for them. I have a friend, a retired psychiatrist here, who's getting treatment for acute myelogenous leukemia, and he is paying out of pocket $1,000 a month for part of his chemotherapy that is not fully subsidized. But again, these are exceptions. And overall, Pharmac has resulted in New Zealand having some of the lowest drug costs in the world. And it says on their website that they're the only agency of this sort in the world that operates this way. I'm not sure that that's exactly right, but anyway, I think that we should look at Pharmac as a means of incorporating negotiation of prescription drug prices in any of our plans. And again, going back to the beginning, starting a few years ago, the New Zealand government, the New Zealand Ministry of Health, really put addressing inequities and improving access for disadvantaged populations into their mandate. Even Pharmac has taken this on board, and the last slide, Mike, or the last page, shows one of the ways that they've done that. Well, here, why don't we just stop there for a second? Almost 4 million New Zealanders have received funded or fully subsidized medicines from, and the medicines go to local pharmacies. There are very few pharmacy chains. There's very little mail order pharmacies. You just go to your local neighborhood drugstore and get your prescription. And it's costs the same no matter which pharmacy you go to. And also, if Pharmac has any money left over in their budget, which often happens, then they can invest into savings on additional or more medicines. And I have never found the formulary to be insufficient. There are a few drugs that are not available here that are available in the US. But likewise, there are a few drugs that are available here that are not available in the US. And final slide. This is just the example I was talking about, how they're making special effort to Maori and Pacifica populations. That's people from other Pacific islands that are living in the US who have a higher incidence of diabetes than the rest of the population. So they're making a special effort for Maori and Pacifica to get onto new diabetes medicines or get the combination of medicines that they need to manage their diabetes more effectively. And there is zero issue about affordability of insulin and insulin delivering devices, that anyone, regardless of their income and regardless of, well, their insurance status is they're covered, can get whatever they need. They don't have the problems that we have here in the US. And maximum per year they would spend out of pocket is $100. So that's essentially the summary that I put together of the New Zealand health system, and I'd be happy to take any questions. Principles and goals were put forward by the Ministry of Health, by Jacinda Ardern's government over the last 5 years, and really the last 2 years, there's been a big push to reduce inequities and to address disparities. And, you know, we do see that here. For instance, the district health board that I'm currently working in is not as, the system is not as robust as it is in the larger cities. So they struggle with getting healthcare to people in, or accessing healthcare for people in rural areas, just like parts of the US do. But it's much more, the goals are much more straightforward and specific, that if there is a problem, they will work on it. Things like, for instance, the helicopter services, helicopter ambulance services. Anyone who needs to be airlifted from a clinic or a small hospital in the rural area to the larger cities for emergency treatment or for heart surgery, say, for instance, or transplant or whatever, the air ambulance system is, there's no question about cost. It's budgeted, and it's used if indicated or appropriate.
You asked the question about prescription drug advertising. Is it true that US and New Zealand are the only that permit prescription drug advertising on television and elsewhere? You know?
Yes, that is true. Although I have to say, when I watch television, which I don't too often, there's not a lot of advertising for new drugs. I noticed it more in years past when I've watched television, but generally there's kind of two types of advertising for pharmaceuticals. One is for drugs that are not yet subsidized, and the other is for subsidized drugs to encourage from the companies to encourage people to ask your doctor about. But I have to say, I don't pay attention to it too much because I don't watch a lot of television.
Right. So it's not runaway craziness like we have in the US, I gather.
No.
Yeah.
Say one ad that I can think of is there was an ad for a new antihistamine, which is basically just a different, like a cis or trans formulation of the other drug. I think cetirizine was one of them. And I did look that one up because I wasn't sure what it was, and found out that it in fact is not as effective as the other medicines, but that was for an over-the-counter medication, and over-the-counter drugs are not subsidized.
Okay, thanks
so
for
they
that.
are a little bit more expensive. So a question about the funding of the system,
Yeah.
and it's primarily income tax, although there's a GST, goods and services tax, that is levied on everything. It's kind of hidden. You don't see it because it's included in the price of goods and services. And a percentage of the GST also goes to healthcare. And it's not a set percentage of either what percentage of income tax, what percentage of GST. It's pooled, and the government sets the budget every year based on need and previous year's costs.
Right. Catherine asked, what's the true cost for inhalers?
The true cost, I'll find the resource where you can go and look at it. It's pretty interesting that the true cost is very low, really. For an albuterol inhaler, the cost to the patient is, again, the $3 to $5. The cost to Pharmac, which they publish, is under $10.
Terrific. And that's negotiated.
Yeah.
Thank you for that. So
I mean, I can look that up on the formulary, and I think pretty much anyone can anywhere in the world. I think you can look it up, and in parentheses it'll put the cost to Pharmac, and whether it's fully subsidized or not, and most of them are fully subsidized.
Okay.
A couple of quick questions. It mentioned that you cover the undocumented. Who are the undocumented in New Zealand?
At this point, there's actually very few who are undocumented because the borders have been closed, but they would be people who've come in on temporary work visas to work in the wineries, the fruit orchards, some for working in the restaurants and the tourist industry who then are overstayers and stay on.
Another quick question. Years ago, I heard that one thing New Zealand didn't provide was cancer treatment, and that New Zealanders had to go to Australia for it. Is that still true?
That is not true. That is not true. And in fact, a few years ago, we were traveling and we were in a fairly remote part of the South Island, and we stayed at a bed and breakfast, and they had a barbecue with us, and a friend came over, and he was a retired policeman who had a tongue cancer, and it initially was missed by his primary care doctor. It was missed by a dentist that he went to because he was having some jaw pain. Maybe it was a jaw cancer, I can't remember which. But anyway, once it got diagnosed, he had surgery, and then he required a long period of rehabilitation and plastic surgery, and then came back home, and he was awaiting going back to have that revised, and he had chemotherapy, and it was all paid for, even the transportation from the west coast of the South Island to Christchurch. And also he would have had his stay in an apartment nearby the hospital paid had he not had a sister who he was able to live with. So cancer treatment is fully funded, but not for, if I were to get cancer, I would need to come back to the US for treatment because I'm not a resident. And my travel insurance wouldn't cover it. And now that I'm on Medicare, Medicare doesn't cover treatment in New Zealand either. So I'd have to come back to the US for that.
Thanks for debunking the myth there. And let's pivot over to Henry Broska. Henry?
Hi, Julie. It's really,
Hi.
really interesting. I'm in Orange County, California, but I spent 60 years living in Canada in the healthcare system there.
Right.
I noticed that you have a user fee for an office visit. Is that true?
Yes. That's, I think, the thing that should be changed here if they were going to put even a little bit more money in. There are patients visiting their primary care physician pay anywhere from $10 or $15 if they have what's called a community services card, if they're on a benefit, up to $50, $60, $70.
I noticed
visit.
the office visits per year where there are 4 in the United States and about 4 in New Zealand. There are about 7 or 8 in other countries, so it's pretty low. And although your outcomes seem to be better because it's almost a 4-year gap in life expectancy,
Right.
so people are treated pretty well. That must be a barrier to primary care is important because your primary care doctor sets up the rest of your treatment for you with specialists, correct?
Right. It also creates an issue. For instance, I'm a psychiatrist, and if someone is well enough to go back to their GP, because we're only funded for about, people say 3 or 4% of the population. So, there's people, once they're stabilized, they go back to their GP, but a lot of people don't want to do that because then they have to pay to see their GP, whereas it's free to see the specialist, free to them.
Terrific. Thanks so much, Henry and Julie, for the exchange. Mike Huntington, then Lynn Cheney, and then I have a couple of backup questions from the chat. Mike?
Yeah, average salaries, primary care specialist.
Yeah, I had that I was going to put it in a slide, and I neglected to do that. Primary care salaries are between 130,000 and 180,000 a year, and specialists are between 140,000 and 250,000 a year. people can make more money if they're wanting to be on call more often. Let's see, students coming out of medical school have a much lower debt. Their kind of maximum tuition, if they don't get any subsidies, is $15,000 to $20,000 per year, and that's New Zealand dollars. And I don't know about trainees, as in interns, residents, what they call RMOs here.
Thank you.
Terrific. Thanks, Mike. Thanks, Julie. Lynn Cheney, Maine.
Yes. Hey, Julie, do you know how the healthcare costs are escalating or changing, say, over the last 4 or 5 years in New Zealand? Or is there a yearly cost?
You know, I don't know. I believe, well, costs everywhere here have been going up because of, well, I'm not an economist, but you know, the housing costs and the costs of building supplies, et cetera, have skyrocketed over the last couple of years. But the healthcare costs, I believe, are increasing similar to healthcare costs in other countries that have universal healthcare and that have budgets. Salaries go up based on both experience and a cost of living increase. And the unions, the nurses unions and the other healthcare providers unions negotiate salaries. And that's one of the biggest sources of cost increase. But again, I can't answer a specific percentage.
Okay.
Data yet to show whether there's progress being made on the question of equity? I think it's over the last 5 years. Is there enough data to indicate you're getting traction there?
I'd say that there's not data yet, that we don't yet know the outcomes.
Fair enough. And
I know, for instance, in inequities, there were significant disparities in the rollout of the vaccine, in that the uptake in the Maori community was a lot lower, and there weren't enough additional resources devoted to staff people to get out and educate and vaccinate. Having said that, something like 94% of the eligible Caucasian adults are doubly vaccinated, and under 90%, 87% of the Maori population is vaccinated. 99% of the Asian population is vaccinated, and well over 90% of the Pacifica population is vaccinated. And that's all available on the Ministry of Health website. So there's probably the breakdowns for ethnicity in other services as well.
yeah, I mean, just from the coverage we've seen, New Zealand has certainly been a global leader in taking on the COVID issue, for sure. Let's see, we've got Mike Huntington, Rich Shannon, and 6 minutes. I want to bring up Catherine in the back end just to announce the conference. Mike Huntington.
Yeah, as you know, Julie, the U.S. is a champion at finding wedge issues to divide us. Do you see that kind of happening in New Zealand? When we were there in 1976, abortion was a big issue, and I had never even heard of it before then. I'm thinking also immigration, vaccination, race, gender. Do you see those kind of wedge issues, or national defense with China and Russia and U.S.? Are these wedge issues that you see?
I'm looking over at my husband. I don't know if he heard that question. I would say that that there is a group of New Zealanders that follow the lead of Donald Trump and other conservative extremists. Right now, there's a vaccine mandate protest, and it's not super well organized, but it's growing. And there's a very small percentage that are anti-vaccine, but a larger percentage who are anti-mandate. But again, it's a much smaller percentage. Yeah.
Thank you.